Good morning and welcome to the press conference for the 2017 annual meeting of the Society of Thoracic Surgeons. I'm Dr. Robin Cohen, Chair of the Workforce for Media Relations and Communication. Our next paper to be presented is entitled Lung Cancer Screening in the Community Setting, Challenges for Adoption. It'll be presented by Simran Randhawa from the Einstein Healthcare Network in Philadelphia.
Thank you, Dr. Cohen. Good morning, everyone. I am here to discuss lung cancer screening in the community setting and the challenges for its adoption. As we all know, lung cancer is the #1 cause of cancer-related death in the US and worldwide. It kills more women than breast, ovarian, and uterus cancer combined. Every year, there are approximately 225,000 new cases of lung cancer diagnosed and approximately 160,000 deaths per year in the US alone. So deaths from lung cancer surpass mortality of all other malignancies, and lung cancer can occur many years after tobacco cessation. Majority of lung cancers are found at an advanced stage, and the 5-year overall survival has only marginally improved over the past 40 years by approximately 17%, according to recent data. The survival clearly correlates with tumor size, and 1 centimeter size increments are now the new cutoff points in the 8th AJCC staging edition, meaning smaller cancers have better prognosis. Some of the pros of lung cancer screening with the help of the low-dose CAT scan include the fact that lung cancer is highly prevalent in a high-risk population. It helps detect early-stage disease, leading to a clear survival benefit, and it is indeed a non-invasive method. Some of the cons include the CAT scan of the chest comes with some radiation exposure. The false positive rates are somewhat high, but still competitive in comparison to mammography and PSA levels. And it does add an additional financial burden to the healthcare system. Risk factors for lung cancer include tobacco abuse, the amount of cigarettes smoked, as well as the total duration. And there is a change in risk with smoking cessation. Some of the other risk factors include secondhand exposure, outdoor air pollution, occupational exposure, radon, and pre-existing lung disease such as chronic obstructive pulmonary disease and pulmonary fibrosis, as well as genetic predisposition to a smaller extent. As we all know, smoking cessation helps decrease the number of overall lung cancer deaths in the US. But despite the success, 160,000 people still die every year from lung cancer. And most people who die from lung cancer today are former smokers. Approximately 50% of lung cancer is diagnosed in former smokers. And the 5-year overall survival is marginally improved from 12% in 1975 to 17% today. Former smokers cannot benefit from primary prevention. So this is where lung cancer screening comes into action, and it helps find disease at an early, more treatable stage. The goal of lung cancer screening is to decrease mortality. The NLST in 2011 showed a 20% relative reduction in lung cancer death with annual low-dose CAT scan of the chest in high-risk patients. High-risk patients being those between the ages of 55 and 74 years, those with a 30-pack-year history, current smokers, or those who quit less than or equal to 15 years ago. The reduction in mortality of any cause was by 6.7%. The number needed to be screened to prevent 1 death is 320, which may seem like a lot, but it is a very competitive number when compared to mammography or colonoscopies. Lung cancer screening is also cost-effective. It costs about $73,000 per quality-adjusted life years, which can be further improved if offered with smoking cessation intervention. In 2011, NLST was published in the New England Journal of Medicine, and there was strong endorsement of screening by the NCCN. Of particular mention, there was early and strong endorsement by our society here at the STS and AATS. In October of 2013, we offered a free lung cancer screening program in our community hospital. And in a couple of months, fortunately, the U.S. Preventive Services Task Force recommended lung cancer screening on par with colonoscopy and mammography. In Feb of 2015, the CMS covered lung cancer screening. The purpose of our study was to determine feasibility of establishing a lung cancer screening program in a community health system, to identify the barriers towards its adoption, and to benchmark our experience with the NLST results. So we offered a free lung cancer screening program to the patients in our community hospital and promoted the screening program through flyers, radio programs, face-to-face information sessions, as well as a multidisciplinary lung symposium that we had organized for all the primary care physicians. We prospectively collected our data over 12 months with the help of a lung navigator, and the patient eligibility was decided based on the NLST criteria. The results were reported using Lung-RADS, and at the end of our data collection, we sent out an online survey to all the primary care physicians and referring physicians. So the average age of our population was 64 years, comprising of 60% of females and 65% African Americans, which was in contrast to the NLST data in which about 60% were males and 90% were Caucasians. Our average pack years are 43, with majority being current smokers. So 88% were diagnosed with Lung-RADS 1 or 2, meaning benign, and 7% were Lung-RADS 3, meaning possibly benign, requiring close follow-up with a CAT scan, and 5% being Lung-RADS 4, meaning suspicious finding. Out of the 11 patients who were diagnosed with Lung-RADS 4, 4 patients underwent life-saving lung resection surgery for stage 1 disease. 1 patient was diagnosed with stage 4, and the remaining were either benign or on follow-up or lost to follow-up. On further investigation, we found that 60% of the patients that showed up for the lung cancer screening were actually referred to us by the primary care physicians. 22% had heard about our program through flyers as well as radio, 2% via web search, and 1% through newsletters. At this time, we sent out a survey to the primary care physicians. Of particular mention, by this time, CMS had mandated documentation as well as shared decision-making in order to cover for lung cancer screening. So then we asked our physicians if they had referred any patients to our screening program, and if so, how many. About 42% said they referred less than 10 in the last 1 year. 42% said they referred more than 10. However, 16% physicians never referred a patient. And then when we further asked them if they were even aware that lung cancer screening is recommended by the US PSTF on par with mammography and colonoscopy, 74% admitted to the fact that they were aware. However, 26% were not even aware of this fact. When asked on giving us some feedback about the program and if there were any barriers that they think they may have encountered for a referral, where one physician commented on the lack of time to counsel his patients because he was chronically running late. Most of the physicians expressed concerns about pre-certification and requirement for prior authorization for lung cancer screening. Hence, we concluded that implementing the screening program in a community hospital is feasible and did save lives. However, there are still concerns about time constraints and its widespread adoption, and positive feedback proved beneficial. That is, when we informed the physicians about how the patients they referred to us received life-saving lung cancer surgery, we realized we got more and more referrals from the same physicians. This is an example I adopted from Leahy Clinic. For example, if an individual primary care physician who has a 2,500 patient panel, of which 75 may qualify for lung cancer screening, of which 20 have a positive finding for a lung nodule, and 5 undergo surgery for the significant incidental finding. In that case, if he does 100 screenings per week, that physician may end up saving 1 life every 3 weeks. The limitations of our study are that it was a small sample size, and we interviewed primary care physicians catering to an underserved population in the community, which is not comparable to the NLST population. However, it could potentially be more generalizable. In the future, we hope that there's an evolving technology used for CT screening with reduction in radiation dose, and more accurate biomarkers will be developed to identify patients at highest risk for lung cancers. I adopted this slide as well from Leahy Clinic, the Rescue Lung, Rescue Life movement mission, where we aim to save lives through early detection of lung cancer with responsible CT lung screening. We want to break down barriers and prejudice faced by those at risk for lung cancer, raise public awareness of the power of CT screening to save lives, and provide a platform to explore relevant research questions. Thank you very much.
Very good. So this is hugely important information, and it boils down to a couple of facts. Number one, lung cancer screening is medically indicated. Number two, it's paid for by law. And number three, it's not a secret. But it depends on primary care physicians understanding the indications and ordering it to their patients. And despite huge efforts to educate them, as you've seen, we're experiencing bad outcomes. And if they're not going to order it, the whole thing becomes moot. So this is really important information and gives us an idea of where to go to improve the success of these programs. So others, do we have questions? Yes.
Crystal Benefit page today. So you mentioned that one of the common things that came up was the concern about pre-certification. Is that, but you have a free screening program still?
Correct.
So you don't need pre-certification to get screened, or
So-
you do?
When we started off as a free screening that we offered to our employees and then further advanced it to the patient population. However, during that process, CMS began to cover for lung cancer screening, and at that time, we kind of did not do it, offer it for free anymore.
Okay, so now pre-certification is required under
Correct.
the guidelines that were set out by the USPSTF. And
Correct.
so when a physician sees that, they're not referring because of the burden of that. So
Correct.
what is your solution at your center? What are you doing about that?
I feel like we will get more referrals if they are aware of the life-saving benefits of the screening program. And the pre-certification is a barrier, but it's something that we can encourage our physicians to refer more and more patients to us once they realize how life-saving the whole process of lung cancer screening is.
Let me introduce Dr. Doraid Jarrar from the Perelman School of Medicine at the University of Pennsylvania.
Well, thanks for the opportunity. We made the decision to offer a lung cancer screening program out of our strong belief that this is the right thing to do, sort of in the midst of the adoption by the Preventive Services Task Force and then CMS. We actually had to check with our lawyers because by the Medicare laws, you can't just offer a free screening program where you have to be very careful because there's a clause about inducement of services that drives patients to your institution. So you have to be very careful. So we had that free screening program, but once it was endorsed by CMS, we had to kind of follow the rules. And our primary care physicians and now have to kind of go through the shared decision-making. They have, in certain cases, to have the CAT scan pre-certified. So our concern is that the widespread adoption that we all strive for might be hindered by these by these time constraints on part of the primary care physicians. And we actually we're worried about a drop-off of our referral base in those circumstances.
So some of the centers that I've talked to before suggested that they were going to have specific routes for dealing with concerns like that, that perhaps there would be ancillary staff involved in helping with some of those things that they would set up with the programs. But is that happening?
Certainly, mid-level providers, non-physician providers, nurse practitioners, and physician assistants can be part of that decision-making if it's documented. That is certainly a solution. That's probably not available to all primary care physicians, who should be really the drivers of this campaign to reduce the mortality from lung cancer.
So it's happening at specialty centers, but not necessarily broadly in the kind of centers that it would be referring to you.
And I think our study reflects maybe some more of a real-world kind of medical care, since it was initiated at a community hospital, and we do have serve a very indigent patient population with poor access to health in the first place. We also, as Dr. Randhawa pointed out, we believe that lung cancer screening provides a teachable moment to current smokers. The majority of our patients were current smokers, so we used the opportunity to also initiate smoking cessation initiatives with the patient. Please.
Can you just talk a little bit about how, I think you mentioned to me that you found that in speaking to and providing feedback to some of the primary care physicians, that when they found out that when they recommended lung cancer screening to their patients, and patients then it was found lung cancer and they had surgery, that actually served as motivation for them, and they became champions after that. Can you talk a little bit about that?
So we found out that when we went back and looked at the referring physicians, we found out that 40% of our patients were actually referred to us by top 3 physicians. And they were mainly it was mainly because when we went back and informed them that we found cancer in one of the patients that was referred to us from them, they became very driven, and they tried to refer more and more patients. They took the extra effort to go through, who would benefit from lung cancer screening, and we got more and more referrals from those patients. So I feel like it's something that we can use to win primary care physicians one by one. And it's a slow process, but I feel like, we can do it. It's very beneficial, and they just need to realize that at this stage.
I think thoracic surgeons are very, should be champions of this, but we certainly need to get the word out, and it needs to be a sustained effort. I think as so many times as news get out about lung cancer screening in 2011 and in subsequent years, and it was certainly endorsed by the STS and AATS, but then you certainly, as with so many initiatives, you see a drop-off, and lung cancer screening is not as established by society or accepted as mammography and colonoscopy. So I think it's really a continued effort to make this really work and get hopefully a 20% reduction from lung cancer death in the future.
Can you make a comment about the criteria for lung cancer screening? Some people say that if you quit for 15 years, that you're not a candidate, and to become a candidate, you have to start smoking again.
Yeah.
Does the government need to change their indications for who they'll pay for in terms of lung cancer screening?
So we discussed that yesterday at a roundtable video conference. And the NCCN, the National Comprehensive Cancer Network, actually has 2 tiers for high-risk defining patients eligible for lung cancer screening. And the purest kind of version is modeled according to the National Lung Cancer Screening Trial, and that's what we took those criteria in our community hospital and applied them to our patients. And that's 55 to 74, that's 30 pack years in a current smoker quit less than 15 years ago. There's certainly additional risk factors, as was mentioned in the talk, including COPD, secondhand smoke, and a family history. We're very glad that lung cancer screening was adopted in the first place by CMS and is paid for finally, and it took a lot of work by a lot of advocacy groups for lung cancer. It was not an easy deal and a lot of effort on part of the STS. So we're very happy where we are now with the criteria and the reimbursement. And certainly now is the time to really make it raise public awareness and really of the 8 to 9 million patients who are eligible to get as many as possible.
Other questions? Very good. Thank you.
Okay.
I'm sorry.
Go ahead. Sure. So when you talked about the survival rate in lung cancer, only going from 12% to 17%, that doesn't take into account the checkpoint inhibitors now?
So much has happened. You have to, in the 1970s, the CAT scan was just invented by Dr. Hounsfield. So, and survival back then for all comers was 12%. Now in 2017, and you just mentioned advanced chemotherapy, as we have heard at that meeting, CT scan, endobronchial ultrasound, 250 slice CAT scan, PET scan, brain MRI, but still, the mortality is still very high. 5-year survival is 17%. So obviously, if you look at all these very expensive measures, it seems like that, first of all, primary prevention, tobacco cessation, which has been very successful in the United States, is a great tool and has been very successful, but secondary prevention, a low-dose CAT scan of the chest seems to be sort of the next logical step. And we do know now in the 8th edition of the staging manual that size is so important, and we can probably achieve an 80–90% 5-year survival in lung cancer if we find it early, sort of on par with what we see with breast cancer, where survival rates have really improved markedly over the last 20 years. And now we know that if you find a lung cancer that's 1 cm, the 5-year survival is 90%. If you find a 2 cm lung cancer, both are still stage 1. That drops probably to 75%. Though both are still stage 1. So really finding it very early and removing those or treating them by various means is very important.